Good morning, Professor Duncan. Thank you very much for, allowing us to do this podcast with you. I know your time is pretty tight, so this is a very good opportunity for us. Welcome to Japan. How do you feel about, the country so far?
Yeah, I mean, it's funny. It's the first time I've ever been in Japan. I've been in Asia before, of course, to China and to India, Hong Kong, Sri Lanka, but not to Japan. So Japan has always been associated with dentistry for me and with progress,
Mhm.
electronics, cars. So it was always interesting to come here. It's hot, it's humid,
Yes.
but it's very friendly, very friendly. So far, very nice impressions. Thanks.
Have you been to other places in Tokyo? Like, where have you visited so far?
Well, I'm here with my daughters, so we were in Disneyland.
Okay, obviously, yes.
I'm not sure that's a flavour of Tokyo, but it's one flavour of Tokyo. We also went to the centre of Tokyo. We went to the busy crossing.
Oh, okay.
We did some of the tourist things as well. So
Yeah, perfect.
yeah, but I've enjoyed it. Enjoyed the cuisine, the cooking, very interesting. And as I say, yeah, the fashion very different in Japan from Ireland, and the culture. But yeah, really enjoyable so far.
I'm glad you're having fun. So, Professor Duncan, I stole some of your CV, from the ESE, sorry, website. I could read this, but I would rather if you introduce yourself by yourself. So, how would you introduce yourself?
Well, I'm currently a professor in Trinity College in Dublin, which is the biggest university in Ireland. I'm not from Ireland. I'm Scottish. I'm from Glasgow. This is not an Irish accent. It's a Scottish
That's what
accent.
I thought.
Yeah,
That's what I
which confuses everybody, including people in Dublin. My family are Irish, but I'm Scottish.
Okay.
So I've ended up by a long route, like your own, I guess. I've ended up in Dublin, where I lead education, research, and teaching in that university for the last 15 to 20 years.
Yeah.
It's a nice place, Ireland. It's to work, nice place to bring people up, nice climate, and it's been useful to develop some of the ideas we've had within research and education within that university. At the moment, I have other commitments outside the university. I'm the editor-in-chief of the International Endodontic Journal, which is the highest impact factor journal in endodontics, and I think number 5 in dentistry field, which is very good. I'm also at the moment the president of the European Society of Endodontology, which is possibly the largest global endodontic organisation with about 8,500 members. So it's a very large endodontic organisation.
Yeah.
Which allows us, it's a privilege to lead that group. It's a federation of 27 to 30 countries who are all members of that group. So in that role, we've been developing guidelines and position statements and
I
work
have
of
a few
that
questions
nature.
about that. Yeah.
Because what's really appealed to me, and it'll come out during perhaps this podcast, is we do a lot of primary research, sometimes with industry like GC, sometimes in my own lab. But then we talk to dentists and they're either unaware of the research or they're aware of the research and ignore it, which is the other problem. We have a challenge in dentistry is how we get dentists to understand research and apply it in their practice. Otherwise, you get people like us doing this research, which we think is great, but no one actually bothers to implement it. And without implementation of research itself is almost pointless. It has to be implemented and disseminated and understood. And guidelines and position statements are a very useful way of doing that, or distilling that information into sort of understandable pieces. And that's what we're trying to do in the SE at the moment.
I was doing some research and I see you just published a clinical practice guideline.
That's an really interesting point about clinical practice guidelines, because we didn't have one in endodontics before. You may know that the perio group, the periodontology groups, have done this in the past, but we had a very good, well-cited document in 2006, the ESE Quality Guidelines, it was called, in endodontics, and lots of people read it. But when we went to republish it and rewrite it in 2020, it was very clear that there was no process. It was a bunch of people got in a room and they wrote these guidelines based on their own experience. And we were told by medics You can't write guidelines this way
Not
anymore.
like that, yeah.
Not anymore. You have to go away and look at the evidence systematically and analyze the evidence on really strict guidelines, come up with what are the findings, what do we know, what do we not know, without bias. And then once you find out what you know and what you don't know, and it might be that we know a lot about some things, like instruments perhaps, but we know very little about biological questions. And you have to be honest about that. Yeah, we need more research here. Or at the minute, we can only with very limited certainty say that you can do this. But we can say with great certainty that it doesn't matter what nickel titanium file you use, because both will do a very good job if you're properly trained.
Yeah.
So there's some things you can, and that's what the guidelines were useful in doing. I think they were useful in highlighting very clearly in endodontics what we know and how well we know it,
I see.
and also what we don't know.
Yeah. And honestly, it's not a small document. I downloaded it, and
No, it's
I cannot say that I went through all of it.
Yeah, and I think
it's a very, big
I
one.
think that's what most people will do.
Yeah.
I think it took me a long time to write it.
Yeah.
So I know how long it is. I think what's interesting from it is the recommendation tables. I think people should dip into it to pick out the recommendations.
So that's what I was going to ask you. Like, how do you recommend people to go about, this kind of, this clinical practice guidelines? So
Yeah, I mean,
do they go through the whole thing?
no, I don't think so. I think only a masochist or someone who's got an awful lot of time on their hands will go through that entire document. But I think what people tend to do is we're doing what we call an adultment process, in which we're translating it to different languages, and we're also simplifying it, or trying to simplify it into what we would call bite-sized pieces. Because if you're interested in, how do you best instrument a root canal system, you might look at the instrumentation of the non-surgical root canal. If you're interested in vital pulp treatment, you'll look at a different part. And I think that's the way people will use it, more like a reference document or encyclopedia. They will look at the various parts they want an answer to, rather than reading it from start to finish. I think that's a much harder task.
Yeah, it's quite a large amount of information to go through.
Absolutely.
Yeah. If I may ask you, what got you into endodontics in the first place?
It's interesting. I teach a lot of students now, and I think the generations have changed. You maybe notice this with younger people that come into your company, but the young students these days have very strong ideas what they want to do when they're dental students. I want to become an orthodontist. I want to become oral medic or oral surgeon. Or in my day, when I was a dental student, it wasn't really this way. Most people assumed they were going to go to general practice. And I was no different. I had no really assumption I was going to do anything after I left other than go to general dental practice in Scotland. And that's what I did. I went to general practice in the middle of Scotland, a place called Alloa, which is a small town in central Scotland. And I had a very, very interesting boss. He was a guy who was just before retirement. He was not interested in being a specialist. He'd never done a further qualification, but he really loved dentistry. And he loved progress, and he did a lot of root canal treatment. And he said, there's a future in doing root canal treatment. I see this is where dentistry is going. So he spent a lot of time mentoring me, and I thought, I really quite like this. I didn't like...
Really?
I quite liked it because a lot of people like aesthetics, and
yeah, right.
I like treating disease.
I see.
And endodontics is treating disease.
Yeah.
And you don't have to use a technician, which is a bit of benefit for those who know dentistry. And you don't have to get worried with patient aesthetics. We do get involved with radiographic aesthetics, but that's just a professional thing.
Yeah.
You're dealing with the disease and treating the disease, and it's just you and the patient. So for certain personality types, endodontics suits them. So that's how I got into the endodontics. It was after I qualified. But there was no courses. There was no specialist courses in Scotland. And I'd never left Scotland, so I went at that time trying to find places who would do specialist training, because the only places you could do it were London at that time, Amsterdam, or America. Within my area, you could probably have done it if you'd come east, but very few people have ever gone east. So I eventually went to London to do it with Tom Pitford and guys to do endodontics via Northern Ireland. I went to Belfast first, because in those days you had to have a fellowship examination, which was an FDS first, before you could do specialist training in the UK. Did it in London, and that really opened it all up for me after that, because then you could decide what you want to do. I did some research in Zurich, which is more expensive than Tokyo even.
Yeah.
It's an extremely expensive place.
Yeah.
And started getting an idea about research. Went to New York to do some research in New York in the American system, which is great for research, maybe not great for other aspects of dentistry, but it's great if you want to do research. And then came back to Ireland, to Dublin, and then did a PhD in Birmingham in the UK in pulp biology at that time. So, yeah.
So you've traveled all over the place, and obviously along a very long, long period.
Mm-hmm.
How do you see endodontology development throughout these years? Like, what changed?
Yeah, I think there's been fundamental changes. The big revolutionary change early when I qualified was the invention or the development of nickel titanium instrumentation. Because before that, specialists were doing it by hand, molar root canal treatments, 6, 7 molars. That's hard work.
Yeah.
It's hard work for your fingers. It's hard work for, and the development of these mechanized systems that were really efficient and effective in nickel titanium was a real change at that time in endodontics. And then since then, the development of bioceramic or hydraulic calcium silicate cements was also a huge advance. But as I see it, and I don't have every endodontist on board in this idea, but the way I see endodontics has to develop is it has to become more minimally invasive. Endodontics and root canal treatment is, in dental terms, not in medical terms, but in dental terms, quite an aggressive technique. You have a small injury to the pulp, you take the whole pulp out, you do a root canal treatment, you then put a post in perhaps, and then you do a crown. That's actually quite a lot of dentistry to solve quite a small problem. And I think dentists have to think slightly more biologically here and a little bit more like our medical colleagues. We have to take away less tissue. If there's healthy tissue remaining in the pulp, we have to maintain that healthy tissue, or even consider regenerating some of that healthy tissue. Because that's the way the medical field has gone. And I always use the analogy, if you go to see a doctor now and you had a problem with your knee when you were skiing or cycling or running, and they opened your whole knee up the way they used to, you would think this is extremely old-fashioned.
Yeah.
They would do a keyhole procedure. They would go in minimally invasive. They'd tidy it up with a microscope and then put it back together again. In the basis that if you had a bigger problem, they may become more radical the next time. And we don't do this in dentistry. We go to the end point very often in endodontics or in root canal treatment before we consider this at a more conservative. And I think that's the way I see endodontics ought to develop. Hopefully will develop in the next generation, because I think we have to progress our thinking in endodontics to stay relevant.
Something that is very scary is when, you're preparing a cavity and then a little blood comes out. And then you're left with the decision.
Yeah,
either go all the way in or not. So
yeah, we did a little bit of research looking at the psychology of pulp exposure, and it's quite interesting because for dental students, pulp exposure, as you just described it, is terrifying.
Yeah,
it's seen as a negative fear, anger, denial, all these things about how this pulp exposure has happened. But in actual fact, and a part of the reason for that, we've come to the conclusion is that for endodontists, that's what we do every day. You deal with pulp exposure. But within operative dentistry, which most people are operating in, that's a problem, that pulp exposure. Very often the dentist doesn't know what to do with that. Should they have not removed the last bit of deep caries?
Yeah.
Should they then remove part of the pulp? Should they remove all the pulp? There's a decision-making process then, which is unfortunately not backed up by really strong consensus. Some people will do a root canal treatment, some people will do a pulp cap, some people might do a pulpotomy, some people would do, and none of it people are really sure of why. They just done it for a series of reasons. They've always done it. And part of it stems back to, if you remember your undergraduate education, or you come to Dublin or you go to Tokyo in these dental schools and you look at how students are taught, they'll have a long lab course on root canal treatment. For example, they'll have a long lab course on how to place a restoration and cut a cavity or a crown. They will never have a lab course on exposure of pulp and what to manage about pulp exposure. It's something that happens in the clinic. So therefore, that's quite a shock to a dental student who's always been used to doing things in an organised fashion. So I think what has to happen in terms of dental education to make this easier is we have to use these beautiful 3D models we now have available, which you can mimic pulp exposure. We have them in Dublin quite a lot. You take away soft wax and the pulp exposed and you get a little bit of red ink or something comes out the pulp. And I think it demystifies a little bit of this problem you've just discussed. And it brings it back into the training area, and people can then have discussions about what do you do in this situation, how do we manage this? Because it has to be something we teach students. It's not a problem, but they need to know how to manage it.
Right.
And we need to manage it correctly, otherwise we will needlessly probably cause a lot more invasion than needs to happen.
If there was one tip that you would give to people who are a bit confused about how to work with pulp exposures, what would it be?
I think the first thing I would say is don't be frightened of the pulp. Because people are anxious about it. People are anxious about applying sodium hypochlorite about it. They're anxious about removing it. And oddly enough, the pulp is extremely resilient. It's not a fragile piece of tissue. If you take a high-speed burr and you put water on it and you drill into that pulp, you will not kill that pulp. The pulp is actually remarkably resistant to mechanical problem. It's long-term infection that kills pulps. So you've got to treat it carefully, but with confidence. So if you expose the pulp, there's a tendency immediately to not do any more. What we're trying to teach the students now is if you expose the pulp, remove all the rest of that soft, carious bacterial challenge, take a high-speed burr, drill into that pulp, remove 2 or 3 millimeters of tissue, soak it with sodium hypochlorite, things we were taught not to do in the past, drench it with sodium hypochlorite, stop the bleeding. If the tissue looks healthy at that point, restore it with one of these new materials we have, like hydraulic calcium silicate cement. So in other words, what we're really doing there is we're treating it with confidence, carefully, but not being frightened to go into the pulp to get it to respond.
And that probably comes out from knowing more about the biology of the pulp, right?
Yeah,
from all the
absolutely.
research that has been done, right? So I know you do a lot of research regarding
absolutely.
pulp regenerative therapies also.
Exactly.
So where do you see this? What therapies are you thinking are going to come in the next?
Well, what we know about pulpal damage, and this is important, is this is logical, is the pulp will defend itself. The pulp is very good at defending itself. It develops by producing primary dentine, and when it's challenged, it will produce tertiary dentine, as we call it. The pulp will not become really inflamed. In other words, severely inflamed until the caries process, let's use caries as an example, is very close, about 0.5 millimeter from the pulp. And even then, the inflammation is severe only underneath the lesion. So if you think of that in real terms, the pulp chamber has got severe inflammation in it, or parts of the pulp chamber. The radicular tissue is actually very healthy. From all the histological studies we have, there's no inflammation in those radicular, unless it's a very advanced case. So with that in mind, and we think biologically, we can just remove or try and remove the part of the pulp that's causing the problem. This is why the pulpotomy concept of removal of part of the pulp, rather than all the pulp, has been a considerable breakthrough in how we might perform dentistry. Not every dentist is keen to do it. And part of that is based on the old direct pulp capping theory that didn't work. But direct pulp capping was not always effective in the long term. We've got good research to show this, because you're not removing that superficial inflammation. You're just simply pushing the material on top of the superficial inflammation. And that might work in some cases, but over a period of time in other cases will not. The other thing to think about is if you remove some of this pulp tissue that's inflamed, can we develop therapies that then regrows some of that pulp and dentine? And I think that is something we should really be thinking about. There's been a lot of research in so-called regenerative endodontics. In other words, finding a replacement pulp if you remove the whole pulp. That's a bigger challenge, because there's necrosis, this biofilm inside the root canal. Much bigger challenge to get stem cells and other cell types to regenerate at that point. But there's no reason why we shouldn't be thinking from a regenerative perspective how we can replace some of this damaged tissue.
Especially right now, there are new stem cells that are. I did my research on iPS cells.
Oh yeah, well, very interesting.
Yes.
Yeah, and just cells, yeah, absolutely.
So there are options also to kind of maybe go that route also. But even though I think it might take a
well, it's interesting what your views on this would be, because you've done some work on this, and as you know, these cells, these regenerative medical techniques are used quite a lot in general medicine, but not much in dentistry at the minute. Partly perhaps because of cost, partly because that we would need what we call good manufacturing process. You need somewhere to remove the cells, expand the cells. But then if you were using a stem cell population, then have to put them back into the tooth. So from a practical dental office point of view, it may not be practical.
Yeah.
It could be practical to use some of the stem cells that are already in the tissue in some sort of cell homing technique, or try and use it, because it's for dentists that's much more akin to what they do in their dental office. But I absolutely agree with the sort of thing you're talking about. We ought to be harnessing some of these cells that are really easy to access for dentists. I mean, they're right in front of them in dental pulp.
Yeah, that's
We
right.
kind of ignore it, don't we?
Dental pulp stem cells are population, right?
Yeah,
Even
they're
though I think
population.
the amount is quite limited.
It's about 5% of in shed cells for deciduous teeth. 5%. It's 1 to 2% of a permanent tooth. So it's limited for scap cells, and those are cells. Those are stem cells of the apical tissues. They're also present. So there's lots of dental populations.
Yeah.
And there's no doubt, I think, though, that stem cell or progenitor cell population contributes to the reparative tertiary dentine. I think they are definitely players. So I think we could utilise them within therapies.
Right. One final question. I'm not going to take much from your time.
Okay, no
but,
problem.
clinically speaking,
Yeah.
how do you see, like, especially with these digital technologies available right now, are you seeing some breakthroughs happening here or there? Like, do you see some practices that are going to be a lot more? So obviously microscopy is one of the things, but I think they reach up to a limit and you cannot see through the, the working area.
Yeah.
But
I think it's interesting because we have had a lot of discussion in the journal and in the ESE and with students about the potential impacts of digital dentistry or artificial intelligence being particularly challenging to the and some people see artificial intelligence in dentistry as a real challenge. Some see it as the real hope. And I think there's a little bit of both. If you look at, for example, radiology, CBCT scans, we could use these scans artificially to program stents or splints. We could actually, if you take this to its nth degree, artificial intelligence could eventually create robots that could do root canal treatments. And this is because this is what could happen in medicine.
You're scaring some dentists right now.
Exactly, this is the problem with scaring people. So it's a case of trying to understand this technology and how it might help us. Because there's no doubt that artificial intelligence and radiographs, just to choose radiographs or x-rays as being the most obvious, a lot of the diagnosis could be done for dentists. As soon as they take a digital scan, it could tell you what is wrong. It could tell you the caries in the mouth, it could tell you the apical lesions in the mouth, it could tell you where the sclerosis, where the canals are visible. It could give you a whole printout within milliseconds almost. That's an opportunity for dentists, not a threat, because that could then lead them to almost treatment plans immediately. So I think in terms of development of a digital workflow with artificial intelligence, even the most reluctant dentists will engage slowly with these developments. It's interesting how far you go to teach this, because we've had this conversation in Dublin. How far do you integrate digital dentistry teaching within the undergraduate curriculum? Because some of our dental students will say, well, I'm going back to live in a country which is not a particularly wealthy country. We don't have the access to this. Others will say that we need more of this because we're going back to a place where everybody's doing this. So you have to integrate it into the curriculum, but it's as soon as you teach it or you get it changes. It's changing almost. I mean, I said monthly. It is almost developing monthly, but it's absolutely going to shape dentistry in the future, like it shapes medicine.
Yeah. Well, thank you very much for sharing your thoughts with us today.
Not at all. I hope people understood what I was saying, but that's fine.
Pretty sure they are. They will.
Right.
Thank you very much.
No problem. Thanks.
Appreciate it.